Hello and thank you for your interest. My name is Dorothee von Moreau. I am professor and head of the Institute of Music Therapy at the University of Music and Drama Hamburg in the beautiful north of Germany. I would like to introduce you to MAKS, or in English MAKS, the Music Therapy Expression and Communication Scale. I started to develop MAKS during my work as a board-certified music therapist at the university clinics of Würzburg and Frankfurt in Germany, and I evaluated the scales in my doctoral thesis at the University of Witten-Herdecke. My colleagues from Freies Musikzentrum München provided enormous support during the whole process of development and evaluation. A big thank to them and to everybody who supported me. Working in a child and adolescent psychiatry, I am often asked for my clinical opinion as a music therapist. Doctors and psychologists know that the client's psychopathology is evident in their behavior. The spontaneous, non-verbal behavior in a music therapy session is of high diagnostic relevance. It keeps important information on the client's emotional state, competences or deficits, as well on their relational and contact behavior, so to say their social competences or difficulties. For the background, it was important for me to follow a phenomenological rather than a theoretical or school-oriented approach. The scales are used for an initial assessment. This is relevant for diagnostics and further treatment planning. A comparison to a final assessment evaluates the music therapy outcome. And last but not least, as an objective, reliable and valid observation scale, MAKS may be applied for music therapy research. MAKS was evaluated with children and adolescents in a psychiatric and a normal school setting. It was also applied for adults in a psychiatric context and with pain patient, and it's suitable for similar fields. As MAKS is a rating scale and observes non-verbal musical behavior, it can be applied for patients who are able to play an instrument in an active way and who do not show motoric or cognitive impairment. It gives information about the client's psychopathology, not their, for example, developmental state. MAKS was evaluated in 2 evaluation studies, first in 1996 with 10 adolescents of different psychopathology and 52 untrained raters with a retest design, and secondly in 2010 with 62 psychiatric and healthy children, 3 trained raters and an assessment 3 times during therapy process. Parts of the English version were validated as well. MAKS proved to be interval scaled and showed sufficient objectivity in most items with trained raters. A retest study and Cronbach's alpha presented efficient reliability. In terms of validity, MAKS proved a stable structure, tested by factor analysis in the first study. It also showed the independency of items and a significant difference between patients of various psychopathology. Relevant for MAKS validity is also significant sensitivity of change over the treatment period tested in the second study. When we formed groups of similar MAKS scores, we found that these groups differed significantly in their clinical state, not in age. This was important for us because we did not intend to construct a developmental scale, but a scale representing clinical psychopathological groups. We also saw that MAKS scores correlate to aspects of psychopathology tested by the Strengths and Difficulties questionnaire and temperament or character tested by the Junior Temperament and Character Inventory. So in conclusion, with these psychometric results, MAKS is suitable for research in order to produce objective, reliable and valid data with trained raters. Let's come to the process of assessment. We distinguish between clinical and research setting, although I would like to discuss this with the consortium. On this slide you find the suggestions for research use in italics. In my daily clinical work, I have good experience using MAKS also in group settings with the target of an individual assessment. However, the influence of the other group members should be considered. At least for research assessment, I suggest an individual setting in a standardized situation taking 15 to 20 minutes. For the clinical assessment, the instruments can be chosen by the client, and also the therapist's instrument should be selected by the client. For research purpose and good enough technical quality in videotaping, I took a big African drum that can be played by 2 players, as you see illustrated. The assessment in this standardized setting consists of 1 solo and 1 duo play. The verbal instruction and the behavior of the therapist during the assessment are defined in a protocol. In clinical settings, the therapist notes his or her memorated observations after the setting using MAKS. In research settings, the assessment situation is usually videotaped and rated by independent observers. For that purpose, a representative sequence of 20, respectively 40 seconds is selected according to the protocol. Now let us look at the scales and their items. MAKS consists of 2 scales. The expression scale with 14 items for the rating of the solo play, and the communication scale with 13 items for the duo play. The focus of interest for the expression scale is the client's interaction with the instrument, the created musical form and structure, the liveliness and dynamics of expression, and the quality of expression. For the communication scale, the observation focus is on engagement in interaction, formal aspects of the interplay, connection to the other, and quality of expression. Each item is rated on a 7-point Likert scale, and each grade of each item is exactly operationalized. This slide gives 2 examples, the yellow one of the expression scales and the blue one of the communication scale. We assumed and proved that normal behavior is found in the middle grades or medium levels. The next slide shows the 2 scales with all items and their levels and gives you an insight in the rating At the beginning, the red line, and the end of therapy, green line. So for analysis, we can gain descriptive results on an item level, comparing each item from the first and the last therapy session. On a further level, we may build mean scores of different categories gained by factor analysis, which merges items of similar meanings. You see that these categories of the two scales, flexibility, form, power, validity, emotion, independence, and contact, are of high psychopathological relevance. For research purposes, we measure the statistical changes of psychopathological groups and their change through therapy on a categorical or scale level, as we see in the graph below. I'm often asked whether training is needed for using the scales in clinical practice. For research, I clearly recommend a rater's training. For clinical practice, it is also important to be familiar with your client group, to be able to evaluate their behavior. It's also necessary to be aware of the neutral instruction for the client's musical play, to be aware of the own behavior during the duo play, to get deeply familiar with the MAKS items and their operationalization, to rate the predominant and not the seldom but therapeutically favored behavior, and to check the own retest reliability or get a MAKS training, because trained raters show much better reliability. For ethical considerations, I made sure to use neutral, non-judgmental but mindful language for describing even extreme or pathological grade of behavior. As I already emphasized, the MAKS assessment needs to be carried out by a credentialed board-certified music therapist who is trained in diagnostic and in using the scale. Further, it is important that the assessment is carried out within a secure therapeutic relationship in a playful setting with the therapist. The client should be familiar with the instruments, the music therapy setting, and the therapist to be able to show authentic behavior and competences. Therefore, I recommend that the assessment takes place at the end of a first music therapy session or at the beginning of the second session, and not in the last or any exceptionally critical session. In order to avoid bias, the therapeutic attitude and behavior described in the protocol needs to be considered. For research purpose, the informed consent of the client is needed, and all standards for data protection must be respected. The interpretation of data must be done with a professional background and experience of a certified music therapist with attentiveness, respect, and mindfulness. We must always take into account the actual state of the clients, his or her motivation during the assessment, and situational factors of the setting. Although MAKS is evaluated as reliable and valid, we must be aware of the challenges and limits of clinical assessments in general. They are helpful and necessary, but not more than a vehicle. They show an extract of the client's expressional and social competences, but never meet the complexity of the client's real competencies. For further information, please follow the literature and references. You also find listed the master thesis of my students at SRH University in Heidelberg, who supported me in translating and further developing the scales. Many thanks also to their enthusiasm and effort. Thank you for your attention and interest, and if you have questions, please contact me.